I would like to invite Dr. Nicholas Chabet from the Philips Research. He is the principal investigator there and also associated with the EMBS. He is the ADCOM member at the EMBS. I will invite him to introduce our keynote speaker.
Thank you, Lei, for the introduction. Thank you all for showing up. It is really our great pleasure to have with us Dale Wiggins. He is Vice President and the Chief Technical Officer for Philips Healthcare, Patient Care and Healthcare Informatics. In his position there, Dale leads several teams that are focused on strategic technology and that plans project inside the US and outside the US, specifically focusing on integration, hospital enterprise architecture, clinical decision support system, interoperability standards, and outcome improvements. Previously, Dale was chief architect for the global patient monitoring business, and he joined Philips from Hewlett-Packard Agilent, where he had held several management, architecture, and engineering positions. Dale has bachelor and master's degrees in computer and systems engineering from RPI. His talk today will focus on applications and opportunities for wearable technologies in physiological monitoring. So please help me welcome Dale Wiggins.
I truly am honored to speak today to such an esteemed group of research technologists. I am motivated by the theme of integrating technology and medicine for a healthier tomorrow. And hopefully I can leave you with a few insights that will help you make this a reality. Philips has been a leader in patient monitoring for over 100 years. If you track our roots back through various acquisitions, it actually goes back to the Sanborn Company, which was a small company in Waltham, Massachusetts, about 20 miles away from here. We introduced wireless monitoring in the 70s with our Hewlett-Packard telemetry monitoring product. So we have a fair bit of history in both monitoring and wireless technology. I don't go back quite that far with the company, but I have been part of patient monitoring and various technologies associated with that for the past 23 years. Now, the motivation for cableless, as we would call it, or wearable monitoring is clear. I show this picture, as an illustrator for the complexity in the system that we face. Many of these tubes and wires and sensors, maybe will never be totally eliminated, but I think we do have the opportunity to greatly simplify this picture if we can think holistically about what actually needs to be done to help improve this patient's life. Now, if you need more motivation, think about how you can improve lives by improving the way infants are monitored during their first few days of their life. Think about the family that cannot hold this baby on your left, or I guess in the first picture. Think about the irritation on the baby's skin due to all these sensors. I think if that doesn't give you motivation to really dig down and come up with solutions, I don't know what will. Now, I mentioned that Philips has a long history with patient monitoring and also, wireless patient monitoring. I'm not going to focus on our products, but I do want to introduce some of our latest products just to give you more of a flavor for what we currently have in the market that I think represents, call it the state of the industry in hospital-wide monitoring. Now, what I show first is our cableless non-invasive blood pressure. It's a wearable measurement device. It's not only the sensor, it's actually the measurement itself. And it actually transmits the information, the measurement itself, in a number of different ways. It can transmit it to a full-blown patient monitor that might be in the room. It can transmit it to translators that can then send it out over the wireless network back to the nurses, back to the clinicians, to a central station maybe. Next, I'll show you our wireless pulse oximetry monitor. Again, this is a fully blown integrated measurement. The patient wears it on the wrist, and it's wirelessly connected in the same way as our non-invasive blood pressure. We also have OB monitors that can monitor the fetal heart rates during a labor and delivery of the mother. Fully waterless or water protected, that the mother can actually immerse herself in water, and this again allows the complete freedom for the mother during the labor and delivery process. And lastly, I show our new, what we call our patient-worn monitor. This young child is actually wearing it around their neck. It's light enough that this child can walk around the hospital and not be encumbered. You just have the one lead set connected to the patient, and then communicates in a number of different ways over wireless infrastructure to get the information back to the clinicians where it actually makes the most sense. Now, we and our competitors are investing considerable time and money into future generations. Some examples here, I represent the My Heart project that's actually hosted out of Europe with our research labs there, working with other industry and also academia in Europe, focusing on ease of use sensors for patient-safe measurements at home as well as in the hospital. Algorithms to detect not only what is the basic signal itself, but what is going on with that patient. Clinicians don't want to know every single heart rate that a patient has. They want to actually have actionable information, and that's where you really need the more complex systemic algorithms that can help to drive that. So when you think about why the emphasis on home, it really is all around avoiding hospitalizations. That's where the most cost is. That's where we have the biggest opportunity to drive cost out of the equation and get patients where they can actually heal better and where they can actually enjoy life. Some of the technologies we're looking at, include smart clothes, the sensors that actually might be part of them, patient devices, algorithms, etc. A lot of times, and I think going through the agenda for this conference, I think we tend to focus on the technologies. I show here some of the technologies that we're familiar with at Philips and some of our research labs, and they all have their applications. All of them work well in some situations under some constraints. But the important thing is to think about how you take it from here, how you roll it up into a system and make real solutions. I'm sure many of you here are probably more familiar with these technologies than I am. And it's really important that we focus on this, and I really look forward to some of the insights that the Philips researchers will come out of this conference with, so we can help to drive these into our products. Things like pressure sensors that can be used in a number of different ways, such as maybe in the bed itself, to eliminate even having a sensor on the patient. I also represent in this next slide some of the technology options that we're looking at for respiration. Respiration is a very interesting measurement in and of itself, because is it the respiration rate that's sufficient, or is it the depth? Is it the fact that the patient is laboring? All these constraints really go into whether or not the solution that you come up with is really an effective patient care device. And then lastly, I saw this last week, I believe, a company here in Cambridge, MC10, I believe is the name of the company, introduced this electronic skin. And this is a picture of it, and it can actually, it's already demonstrated the capabilities to pull raw signals off the patient's skin, use it for heart rate and other parameters. So I think this probably represents the cutting edge technology that I hope we can ultimately fold into our solutions at some point. Now, I suppose that I could drill into each of these technologies and we could have a debate on the pros and cons of them, but I wouldn't, to be honest, I wouldn't compete very well in that debate, so I'm not going to talk about that today. What I am going to focus on is something that I thought would be more useful to those of you who are actively researching these technologies, with the hope that someday they will save patients' lives. What I'll share with you is some of the clinical and healthcare system experiences that we at Philips have faced, as well as the challenges we have and still face in deploying these types of solutions. Most of what I will talk about will have a hospital flavor to them, because that's where my specific part of the business is focused on. But I would argue that the lessons that I'll present here are applicable, maybe even more applicable, in the home environment. So inside the healthcare facility, ambulatory and wireless monitoring, what does that allow? It allows for patients to be able to ambulate. Numerous studies have shown that speeds recovery, minimizes complications. I don't know if any of you are experienced, working in or seeing in the after an open heart surgery, how quickly they try to get those patients up and moving in the unit. Caregivers today are mobile. They need ready access to the patient data. When you can get the data immediately and always from a patient throughout their care, it improves the recognition and response to the patient's condition when it happens. It enables immediate and seamless integration into the EMR. We've done a number of studies where, typically what happens in the care floor is that, things don't actually get entered into the EMR until the end of the shift. That can be 8 hours or even longer after the actual episode occurred. And then ultimately the untethering of the patients using wireless sensors and wireless communication. So this is what we set out to build. As I mentioned before, we call it the cableless patient. Extending where we see the most applicability for this is in the general floor, where most patients aren't monitored today, but yet they're sicker and there are a lot of complications that arise that aren't even known to the clinicians until far later. So what are the key needs? Needs unobtrusive wireless monitoring. We don't believe that just the monitoring itself, just the signals itself are sufficient. You need to be able to analyze those signals, pull them all together, pull it together with other information about the patient history to identify when that patient deteriorates. And I think just as importantly, it needs to be easy to use and integrate very well into the workflow of the clinicians, actually saving them steps, not adding to the already overloaded workload that they have. What I show here in this slide is called automated early warning scoring. This isn't part of, it's currently part of our cableless patient solution. It actually doesn't exist on the measurements themselves. It actually is part of what gets communicated to the technicians, to the nurses, to alert them when a combination of parameters indicate that this patient might need additional level of intervention. We've already done some clinical studies on this solution with our what we call our spot check monitoring solutions. and have already brought about great results in terms of bringing what they call the rapid response team to those patients in need far earlier, reducing complications, saving hospitals cost in terms of not having to treat those complications, and we believe ultimately improving those patients' lives. So we didn't just go about, all right, here we have some really cool technology. Fortunately, we have a great research lab that did put together some really great technology. But we said, all right, how's this technology really going to be used in the hospital? And that's really what I'm going to share with you now. So the first thing we did, we brought together a number of clinical focus groups. And we said, well, how would you use technologies like this? How is monitoring actually practiced today in general care areas? And what we found, here's an example of it. Number one, the monitoring frequency varies by the unit and which vital signs they're actually capturing. Pulse rate and pulse oximetry tend to be monitored most frequently in critical care and step-down units, and then also in the emergency room at least once per hour. Most med-surg nurses monitor the vital signs only every 4 hours. Temperature monitoring actually occurs very infrequently, and often just with an oral thermometer. Patients are often out of the bed, what we measured in a typical 24-hour period, an average of 10 hours, either on the, either ambulating throughout the area or in other areas of the hospital for procedures. Maybe we go to the imaging suite or some other type of solution. Infection control, this has been a huge issue for us in hospitals for a number of years. It's only getting worse. We actually had monitors that, previous generations monitors that the plastics around them couldn't even hold up to some of the agents that they're having to use in hospitals today to clean them. Obviously the preferred is something you can just throw away after each patient use, but clearly that gets into additional cost. It gets into sustainability issues, so there's really not a right answer or wrong answer. Again, it kind of brings back to understand the whole system, understand all the constraints you need to work into. We found that these types of devices are applicable to critical care, step-down units, medical surge. They're all likely fits, but they're likely fits for different reasons. As I mentioned, med-surg, it's to reach patients today that aren't being monitored at all. In critical care, it's to remove some of the complexity, some of the clutter, some of the entanglements that happens with having so many wires around the patient. Clinical is not the only customer you need to worry about. You also have to be very aware of the technologies, the information technology departments in the hospitals, the biomed departments. Very important constituent that you have to appeal to with your solutions. I remember, again, I'll date myself going back to when I started in patient monitoring. We had dedicated networks. The only thing that went on those networks was patient information. Now we have to work with whatever hospital network they've put in play. Wireless sensor technology ultimately needs to be integrated with 802.11 standards. Again, that's what the hospitals are deploying. That's what you need to integrate with. Technology needs to be inexpensive, easy to install in all areas of the hospital. You can't just say that the patient's only going to be in one area. Think about the entire enterprise hospital. Data security, it's a huge issue. You need to be able to use standard enterprise encryption technologies to ensure that that patient information can go from that patient all the way to the EMR without compromise. And then lastly, you have to constantly be focusing on the lifetime cost, looking for full upgradability and easy maintenance. One of the insights that we got from our IT staff was this is really pictured as a quote from them. Hospital administration demands that we implement technologies that improve and support the work processes of our staff. This requires more systems and applications which increase the risk of complications and system failures. I wish every new system added to my network would simply integrate into the existing network without interference and with uncompromised data security. Again, I hope that represents, maybe a proof point behind some of these bullet points here. I show here, and I think we actually have this out at our little booth out there. This is a technology that we introduced with our cableless measurements to address one of those key challenges. How do you get the batteries recharged? Do you come up with throwaway batteries? Not a very sustainable solution. Also adds a lot of expense into your total cost of ownership. So we came up with this technology here where you can basically just lay the measurement down on this little table here. You put one of these in the unit, maybe at the central station, things automatically charged, automatically ready for when the next patient shows up. Now I'm going to go back to the clinical benefits. I talked about, some of the key needs, that kind of drove us in this area. What are the clinical benefits that they expect they will be able to get out of the solution? The key one is keeping an eye on these otherwise unmonitored patients to make sure that no patient deteriorates unnoticed. I'm going to give you again some of the insights that we got from clinicians. And again, these read kind of as direct quotes, even though they aren't quite direct quotes. I know that patients in my unit are sicker now than they were 5 years ago, but we have even fewer staff to take care of them. Patients are not getting the appropriate care, and that makes me feel frustrated. I'm not sure what to do when and who to involve. I wish there was a system that could keep an eye on my patients and let me know as soon as one begins to deteriorate. You can also think about it from a patient perspective. Again, this is one of the insights we derived. This is for the emergency room. When I arrived in the emergency room, I expected immediate help, but I had to wait for hours. I felt ignored and became more stressed as I waited. This long wait is killing me. I can't understand that I might have to wait, but I wondered if they had even forgotten me. I wish when I arrived that someone saw me and I was able to be monitored immediately. Moving on, patient sensors, they need to be easy to apply from a clinical workflow perspective, but they also need to be what I called here patient-friendly. So what do I mean by that? They need to be small and lightweight, obviously, free of cables so they can stay on the patient as they, ultimately are able to go about doing their normal tasks as much as possible. They need to be comfortable to wear, do not disturb or compromise the patient. Need to allow for full mobility, allow them to go into the shower, use the restroom, procedures, etc. You need to allow for them to be easily cleaned. One of the things we hear from patients all the time is, why do the clinicians keep waking me up, disturbing me when I'm trying to rest? All that really gets into disturbing the healing process and impeding, the primary mission that we're in the hospital for. And then lastly, workflow steps. I mentioned it earlier. It's one of the key things you always have to keep in mind. You cannot add steps into the clinician's workflow. Staffs track time or waste time having to track equipment today. They have to fill out forms to put the data back into the EMR. They can't be changing batteries. It can't be fixing disconnected leads and so on and so on. You need to be able to, as I said, reduce the workload, make it easier, allow them to spend more time with the patients. So as a further illustration of, just to bring home this workflow step, I pulled out this slide as another illustrator. We worked with one of our hospitals to actually track how the nurses are actually spending their time. And I'm just going to point to a couple one. That big purple one there, response to alarms. Now, I bet you that vast majority of that time wasn't spent dealing with actionable alarms that actually meant that the patient actually needed an intervention. Far too often we give alarms that are either false, but probably even more often it's just not that important because maybe the alarm settings haven't been tuned to what that patient's condition actually is. You know, another thing that actually doesn't have anything to do with patient care, interaction with the floor, interaction with floor requests. These are the things we need to be addressing from a system standpoint if we're really going to get these solutions introduced into a general floor type environment where monitoring isn't even present. So think about a general floor environment. They don't have monitoring today, so they don't have alarms. How are they going to find the time to be able to deal with alarms? That's a non-starter if you're really going to have a true solution that can be used in those environments. So another constituency is the what I would call the hospital administrators. I think, you know, very few people, I think you probably have to live under a rock to not know that hospitals are under constant financial pressures. We need to take cost out of the system. CIOs tell me today that, you know, it's a zero-sum game. If we're going to introduce new technology into a hospital, we have to take technology, we have to take cost out somewhere else. So we need to be sure that the solutions that we come up with can demonstrate the ability to provide optimal care in areas such as the emergency room, the waiting area. We need to be able to demonstrate a reduction in complications. If you reduce complications, you can reduce the length of stay. It therefore improves the turnover within the hospital, allows them to get more. You might think, well, if I reduce the length of stay, doesn't that mean the hospital gets less money? Actually, no. They get more money by increasing turnover. Turnovers in the bed actually tends to bring in more revenue. And, you know, and that's just strictly from a financial standpoint, let alone the patient outcome. And then lastly, again, all about workflow. How can you get the staff to be more efficient in actual patient care processes? So just a quick illustrator again. You know, this is not a real hospital. I think it actually is derived from some of the work that we've done at hospitals, not with our wireless technology, but in terms of introducing continuous monitoring into general care type areas. And, you know, so if you deal with some basic assumptions about what it costs to treat a patient in the ICU versus the floor, if you look at the basic assumption that all patients that get transferred from the ICU to the floor, how can you really demonstrate the total cost savings by allowing patients to be moved to the floor care earlier and ultimately keep them from having to go back into the ICU because of some complication? You know, it's relatively simple math, but if you can come up with key measures that actually demonstrate that, you have a real winner. So I put together just some of the key operational measures that I think are going to be important as you're thinking about bringing solutions like this to market, as you're conducting clinical studies in the hospital environment. These are the types of things that you need to be able to track and measure if you're going to really be able to come up with real proof points around the financial benefits that a hospital could enjoy from these types of solutions. So just lastly, I'm going to just leave you with some of our early experiences. Again, most of these experiences have more to do with introducing continuous monitoring to patients, not necessarily our new cableless measurements that we're currently conducting clinical studies on. But these are just some of the very specific things that we've observed. We can pick up specific conditions such as atrial fibrillation, right as they happen. Same with ventricular arrhythmias. We can detect maybe, if you have a patient in the general floor, a lot of times their oxygen will fall off. And maybe they're sleeping, maybe they're unaware of it. Their pulse oximetry readings tend to go down. If you aren't continuously monitoring them, you could go 4 hours, you could go a very significant period of time before anyone's even going to notice that. We've been able to detect patients that need to go back to a higher level of care, catching them before they actually crash. I call it a rescue here. If the rapid response team actually has to get deployed, that's probably a failure because that patient's already crashed. We want to be able to know as soon as possible when that patient needs additional care. We've been able to detect a patient that's early septic signals far earlier, bringing them back to the ICU. We've been able to detect patients that are actually at a higher acuity level than what their discharge from the ICU actually said. Again, just saving complications, saving hospital costs, saving lives. But it's, everything has not been completely perfect either. So I have to be, forthright in terms of saying there are still a ton of challenges. The equipment is still not right. It's still not as easy to use as it needs. The placement of these devices have a lot to do with how good that signal is. We have far too many alarms, whether they be false or whether they be nuisance. The cost equation is still not right. We don't have all the studies in place that can really demonstrate the ROI that we need to. And lastly, as I've mentioned over and over, these individual devices, individual signals, need to be integrated as part of the complete system. They need to be integrated to EMR. The data needs to go to the EMR. You need data back from the EMR so that you know what this patient is being treated for, what interventions, what meds, what problem sets do they have, because ultimately I think that's how you're going to drive out some of the alarms that are relatively nuisance today. If you can tailor your monitoring to what this specific patient actually is in the hospital for, I think you can make these things far more predictive to what the clinicians actually have to respond to. So lastly, I'm going to urge you to think outside the box. Don't be constrained to thinking that technology must touch the patient. Think about how you can minimally impact the patient. I may be dating myself again, but I think we are still chasing the vision that Star Trek set out for us in the 60s. Notice that their technology allowed for full monitoring without any patient contact at all. I think that really needs to be our vision. We got a lot of steps in between, and I look forward to a lot of your innovations, and I hope together we can bring them to market and really improve the patient care for all of us. Thank you.
Thank you very much. Dale, is this working? Yeah. And now the floor is open to questions. If you have any questions, just raise your hand and I'll go to you. We'll start with Colin.
Hi, terrific talk, Dale. Thank you very much. I was curious, your talk focused on hospital and acute care settings. Yeah. I was wondering if you could make some comments about the translation of some of the wireless and monitoring technologies from that setting into a primary care and or home setting, because that's where a lot of the push is now towards dealing with issues outside of the hospital.
Right, yeah, that's a good question. We actually do have a home health care business within Philips, so we do a lot of work with that, and we have a lot of projects trying to, how can we bridge that gap, how can we bring the technology, how can we kind of fill that void there. I mentioned earlier that I think in a lot of ways the home environment is even more extreme. Typically I think what you see out there today, you look at the monitoring technology, it's, you got to meet a very low price point, but there's a quality associated with that price point in terms of the measurement and how accurate that is. But I'll just give you an example. We have a Lifeline business. It's the I've fallen and can't get up business. You've probably seen those commercials on that. We recently introduced a fall detection capability in these sensors. So it can detect when a patient falls. Well, there's a lot of technologies out there that do fall detection. But if you think about it from a business standpoint, the difference, in even a 0.1% of a false alarm detection makes a huge difference in whether or not that business can be actually profitable, because you have to have people back at the call center that can actually respond to each one of those alarms. So, and I think it just plays to the system. If you have monitoring, if you're taking a blood pressure reading and it's not accurate, it's not easy to apply to that patient in their home environment, you're just going to basically be generating noise for the system that the system just can't deal with. So I think it's a very complex problem that I don't think anybody's figured out. When you start to go into the patient's home and you deal with the huge heterogeneity of the patient population, different education levels, different experience levels, it beats me how you get that done. But it is, something that we're focusing on, but I think it's going to become far later than some of the solutions that we have here.
Thank you. Any other questions?
Thank you. Since you mentioned Star Trek, I believe that there's an X Prize challenge regarding developing a device similar to the Star Trek tricorder. I was wondering if you were aware, if you could comment on that, or if Philips is involved in that.
Not that I'm aware of. I'd be interested if anybody's got me appointed to that. So, some of the things we are looking at, camera-based technologies. I mentioned that as some of the raw technology we're looking at. So we actually have a demonstrator in one of our research labs where just using a camera in an iPad, for instance, you can actually measure a patient's respiration. You can measure a patient's heart rate. I think there's some interesting applications of that. You could detect whether or not I'm nervous or telling the truth up here if you put a camera on me right now. Maybe put that in the political arena. But that's some of the technology that we're looking at today that really is non-touch, if you will, but it's really on those just those basic parameters today.
I'm wondering if there is a current or emerging standard for sharing physiologic data, like there is for medical imaging. How is Philips going to play together with Siemens or GE?
Okay, great question. Actually, we got a call on IEEE 11073 is a standard that's been being worked on. It's ratified in a number of key areas. Philips has been a very active participant in that, leading that for quite some time. And that's all about how do you get device data from patient-connected devices, connected to surveillance systems, to EMRs, et cetera. We've also been very involved in working with the Continual organization to bring some of those 11073 nomenclature, for instance, standards brought into the continuous, so that we have this continuous nomenclature that's shared both in the hospital environment and into the home environment. We're also working with the IHE organization in terms of bringing some of the 11073 concepts into the point-of-care device domain in IHE that is associated with really coming out with integration profiles based on real-world scenarios in the hospital environment. So it's a very important area. We believe that IEEE 11073 is really at the heart of the solution, and it's something that we continue to lead and push forward.
Any more questions from the floor? Yes.
Thanks very much. I'm more interested for the business model for your hospital solutions. So my question is, who will buy the solutions? Is the hospital or the government will do that?
Who is buying at the hospital or the?
Hospital solutions. Today you talk a lot about the hospital solutions. So I'm interested, so the hospital will buy the solutions or the government will buy it?
Well, in the U.S., it's the hospitals. It varies by geography. In China, for instance, you have government tender processes associated with some hospitals. So, but primarily it's the hospital system itself that buys these type of solutions. As you get into the home environment, you get outside of the direct reimbursement, that's where it gets a little bit more complex in terms of who's actually going to be the payer for these types of solutions. Is it the hospital that are actually going to be, incented or disincented, if you will, for if a patient has to be readmitted within a certain period of time for the same procedure? Sometimes it's the family itself. If you look at our Lifeline business, a great percentage of that is actually paid for by the family itself, and that's private pay. Hospital's hospital, and then once you get outside those doors, it gets into what's currently a pretty complicated equation.
Hi, thanks for your talk. My question is about how much ethical burden does it bring on the doctors? So when you have home care and you've sent this equipment out into the community, and with all the data that's coming in, whether wirelessly or through networking, it does place an additional burden on the caregivers who are now at the facility, but the patient or the subject is not. Would you like to comment on that?
Yeah, it's a great question. It's actually something I neglected to mention in terms of our experiences. When we first started to bring continuous monitoring to the med-surg, one of my personal surprises was the observation that if you are announcing an alarm in a hospital setting or any clinical setting, you are putting a liability on that clinical person to respond to that alarm. If they don't respond to that alarm, they are actually liable. So, forget about the ethical aspect. It's actually the liability aspect, which we all know in the U.S. is pretty severe. So, yeah, I think it's you have to be very careful about what functionality and what capabilities you are actually introducing, if you will, with your specific technology. And in some cases, you actually might want to pull out functionality based upon what the system can actually handle. And, again, I think that gets into the whole, as I call it, the system approach, that you have to understand all these dimensions. How can they actually deal with the information that you're going to give them? And if they can't deal with it, it's probably not a solution. It's a great question.
Yes, sir.
Has Philips done any work with GPS trackers within the healthcare setting, either for patients or equipment or caregivers?
Yeah. Today we don't put any GPS in there. They don't work very well in hospitals. But we do have other technologies that allows for identifying where the patient is. In some cases, we can just use which access point the wireless transducer is actually associated with, and that gives you a close enough approximation, that you can identify where they're at. Another thing that has come up as you start to bring these small devices into the hospital setting, think about our little patient ward monitor. kind of looks a lot like an iPhone. We've had comments like, hey, can I play video games on this? Well, things like that tend to walk outside the hospital, whether or not it's on purpose or whether or not it just gets wrapped up with the sheets or the patient's robe. So we've actually had to put the same technology that you might find in a lot of these high-end clothing stores as you go through this mall to detect when the technology is actually leaving the room or actually leaving the unit that's affiliated with. So it's a lot of those kind of subtle technologies, you do have to make sure that you can integrate them in as part of the whole solution.
Any further questions from the audience? And if not, we thank very much our speaker, Dale Wiggins.
Thank you.